Hi, everyone. Welcome to Dean's Chat, where we discuss all things podiatric medicine. My name is Dr. Jeffrey Jensen. I'm the Dean at the Arizona College of Podiatric Medicine and host for the Dean's Chat podcast. Today, we have two outstanding guests, both young practitioners, and I have followed their careers since they were students at the Bellevue University School of Podiatric Medicine. I'd like to introduce 2011 graduate of Bellevue University, Dr. Peter Highlander from Bellevue, Ohio. Hi, Peter.
Hello. Thanks for having me.
You're welcome. And I'd also like to introduce a 2016 graduate of Bellevue University, Dr. Calvin Rushing from Dallas, Texas.
Dr. Jensen, thank you for having me. Appreciate it.
Well, welcome to Dean's Chat, guys. As a kind of a standard fare, we go by first names on the podcast. So if it's okay with you, we'll go with Peter, Cal, and Jeff.
Yep. Perfect.
Fair enough.
Well, we got a whole host of topics to touch on today, but I just wanted to share just a quick little story from an academic perspective. There's this old adage that successful doctors are like freight trains. You can see them coming from a long ways away. And as your previous dean, I can tell you that I've known you from the beginning in podiatric medicine in your journey, and I'm super proud of you guys, and I appreciate you joining me on the show.
Thank you, Doc.
Yes, thank you. That's very humbling.
So to get started, I thought to set the stage, I'd give each of you an opportunity to talk about how you were introduced into podiatric medicine, how you ended up at Bellevue University, and where you did your residency. And I think that might set the stage for some of the further conversations that we'll have. Peter, would you mind going first?
Yeah. So like Dr. Jensen, Jeff had said, I'm in Bellevue, Ohio. I'm actually practicing 5 minutes from where I grew up. So from there, I went to undergrad at Hillsdale College and small liberal arts school in Michigan. And when it came time to start applying to both allopathic and podiatric schools, of course, I initially concentrated on the schools that were within a couple hours of me. But for some reason, I applied to Barry. I don't know if it was just on a whim. And when I got there, I realized how different it was, being in rural Ohio compared to one of the most culturally diverse cities was amazing and something I had never experienced before. And what really sold me on Barry was the opportunities for rotations. I think, obviously the classroom makes a difference, but I'm a hands-on learner, and being a part of a lot of hospital systems that are in great need, you get kind of thrown in quickly, and that fit me. Obviously, it was a cultural shock for the first semester there, but and to boot, my wife and I just got married that first semester. So, but once that homesickness kind of wore off, it was by far the best, probably most influential kind of thing on my path to date. But from Barry, I was fortunate enough to get a residency spot at the University of Pittsburgh, where when Dr. Patrick Burns was the director, who since just recently left there. But anyhow, after the 3 years there, I got a job about 2.5 hours away from where I am now with a private orthopedic group. And then I got the opportunity to come back home, which was always what I dreamed about. And so I've been back home now for a little over 6 years, and it's been fantastic. One thing about working in rural Ohio, I would assume because I'm not part of a big university system that I wouldn't get quite the diversity of pathology. But that has been quite the opposite. And so my practice has grown, started a fellowship. It's in its 4th year. So this August will be the 5th class. And yeah, things are great.
Congratulations. That's wonderful. We'll delve into a whole bunch of that later. So Cal, I noticed you're drinking out of your Dean's Chat cup.
Yeah.
Loving that. That is fabulous. So I appreciate you for jumping on. I know you've been doing cases all day. How about your journey, Cal? How did that begin?
Yeah, I'll tell you. So I was, I guess we'll call it a military brat for lack of a better word. And we moved around every 2 or 3 years. Dad landed in San Antonio. So I went to a magnet school, Health Careers, right there right there off Fredericksburg and Hamilton Wolf. And it's a unique magnet school in that we get to do rotations with vascular surgery, general surgery, pharmacy, psychiatry, all these things while we're in our, junior and senior years. And to be honest with you, after health careers, I knew a lot of what I didn't want to do. I didn't really know what I wanted to do. And I thought for a while, I think there's a brief period, about 2 years, where I thought I was going to do psychiatry. And it was interesting to me, but I didn't have a natural aptitude for it, right? So I kind of started classes, and I had some of the classes already done from high school, went to college, was doing advanced psychology, social psychology, all these different psychologies. Intramural football game, tore my syndesmosis. It was misdiagnosed as an ankle sprain. Everyone kept telling me you're supposed to be better by now. And, listen, I'm not milking this. I'm not trying to get sympathy. I've been limping around campus for 6 months. Something's not right. And so that was kind of the syndesmotic injury. And that's part of the reason why I do so much research on ankle and syndesmosis, that kind of drew me to the profession at first, just because of the misdiagnosis from a couple of different providers at the time. So I kind of started looking into podiatry. Hadn't heard of it before I ruptured my syndesmosis, before I went down this what was a 14-month journey with that syndesmotic tear that was misdiagnosed by 3 people. I hadn't heard of podiatry very much. And the more I started looking into it, I thought they're looking at the population, any kind of, forecasting for the future. Everyone wants to be younger, healthier, more active, everything else. Just kind of thinking about, I'm a very pragmatic person. I started doing a little bit of research, and I for some reason, I can't tell you why. It wasn't because LeBron James had just gone to Miami, but there was something about Miami that lured me out there to at least the interview. And I said, you want to know what? I'm going to go out there. I'm going to sit down. I'm going to do this interview. I'm going to see how this goes. I'm going to go with my gut. I was looking at other places. I was fortunate in that going to health careers, I got to see a lot of people who were older than me. And if you know me, a lot of my friends are already in there. I'm mid-30s now. A lot of my good friends are early mid-40s. So I had the benefit of watching a lot of people go through health careers that wanted to do certain specialties. And they ended up internal medicine, pediatrics, ER, not what they wanted. Now, they're still very happy. They make a good quality of life. But it was interesting in talking with them about how just because they went in wanting to do these things and they were still happy. And I have, some of my fraternity brothers went in wanting to do general surgery and didn't work out. They're doing family medicine now and happy, but not as happy as they wish. I knew I was drawn to the ankle and foot, and I knew I didn't want to get railroaded out of what I already knew I had an interest in. Didn't know what to expect. Flew out to Miami, very hot. Had never been there in my life. Met you and Dr. Armstrong. And I think at the interview with you guys, I told you guys basically, listen, if it's not Barry University, Miami, then I don't think I'm going to go the podiatry route. This is, I can't tell you what it is. This feels right in my gut. And that was when you guys offered me the spot, right there in the interview. And I'd never looked back, and the rest has been history. I stayed there. I had a great time at Barry, incredible faculty, all so supportive of just the students. The more you want to do, the more they'll turn you on to. And if you're not self-motivated, then, that's okay too. But if you're self-motivated, they'll push you as far as you're willing to push yourself. And that's one thing I think that separates Barry from a lot of the schools out there. But so after that, Steven Spinner, Westside Regional Medical Center for residency. He kind of filled that gap of a father figure for me that I didn't have in my life. He pushed me. He pushed me a lot. I was an introvert. I was terrified to speak in front of anyone. I was always the quietest person in the room. And Steve Spinner used to tell me, speak up. I can't hear you. We can't hear you. You know what you're talking about. Speak up. Make eye contact. And after 3 years, I don't even resemble the same as far as, professionally speaking, the person I was before Steve Spinner. And that's a credit to him and all the faculty there. After that, I went to Ohio with Chris Heyer and at the Orthopedic Foot Ankle Center for fellowship. And that was trial by fire. That was a rough year. That was the best year that I never want to repeat. I'll say that. It paid dividends. It continues to pay dividends. And the people I'm helping now are because I got some of the training there and saw some of that advanced reconstruction. But it was a year I don't want to repeat. And then since then, I landed back in my home state of Texas. I'm here in Dallas, Dallas Orthopedic. We started off as a small group. There's 3 of us. We've added a couple of providers. We're adding 2 more next year. We're growing. And it was kind of interesting because I think I came in at a different time than Peter did. So I came in, it was COVID. So I came in and my practice was trauma. We take all the trauma for the Baylor and some of the other urgent cares. And so my practice first year was heavy trauma, just because nobody was getting elective surgery during COVID. And then it kind of started to morph into a lot of revision surgery as I started helping different people out. And people like to have someone they know they can kick a skeleton to, and it'll get taken care of without being broadcasted. And so I kind of started doing some revision surgery. And so now my practice is a little strange. I wish I did a more elective stuff, but it's a pretty even divide between about 30% revision work and probably 50% trauma, and then sprinkle in another 20% elective stuff. So if you know anyone who needs bunions, I'll do them for free.
That's great. Way to set the stage, guys. So Peter, I wanted to make one comment on, I'll never forget when I was sitting in my office one day and you stopped by to say hi. And it was after you had done interviews, and you came in and you had a whole list of every question that every top program in the country had asked during the interview process. And I remember thinking to myself, that's unique. So that was awesome. And then I wanted to make one quick comment, Cal. I always thought it was interesting. I was so proud of you when I knew you went to Westside. And, when I was your age, 20 years ago or so, a little more maybe, I used to go to CME programs where Dr. Spinner was, because if I did a lab and Dr. Spinner was in the lab, I'd go home feeling like I learned something that I didn't know before I came there. So that's really cool. All right. So that sets the stage for the fun stuff, right? When I was reviewing your CVs, if you guys both retired tomorrow, you've had a successful career. Okay. So I wanted to start touching on one bullet point at a time, and let's just kind of pretend we're talking like we're sitting around drinking beers, and we'll try not to step on each other's toes. But the first thing I wanted to ask about is research and publications. You both have an affinity for it. And where does that come from? I mean, are you creating your own world, or are you just intellectually curious? Wow, where does all this come from at such a younger age when you're starting practice and you have so many balls in the air? Peter, if you want to start, that's fine. Or Cal.
Yeah, I think, well, you hit on it a bit of how I got started enjoying research was, going off on externships. The best questions that I learned from were questions that were practical, right from an article, and what does this mean and how we treat our patients. And so obviously that push towards evidence-based medicine was really prevalent at the time. And, you can make yourself look really good if you could quote articles and whatever. I don't necessarily do that well anymore because nobody's asking me, but it did set a stage, as well as, I will say, Dr. Stelnicki. Well, I should first say Dr. Shaw, who's a biochemistry professor at Berry, that I had an opportunity to get my first publication. In undergrad, I did a lot of scientific writing. And so it just kind of came easy because I had such a good background in it. And I noticed too, there wasn't very many residents or incoming residents that had publications. And so trying to differentiate myself while reading and learning about something that I'm very interested in. That's just how I learn is I have to kind of ask myself the question and be curious and then figure it out for myself. Of course, I listen to the experts and everything, but I want to see what's published. And I also will say, I just recently published a textbook on 3D printing. And in that process, that started during COVID, and really all the majority of the writing was done a year and a half ago. And so if you're reading even an up-to-date, a recently published textbook, there's already been more stuff done. So it's not always the most, most recent publication about the topic. I digress, but then in residency, I had a lot of opportunities to not only do my own research and help others. And I was the research chair 2 of the 3 years that I was there, which means I was the guy that had to do all the IRBs, which is something I don't want to ever do again, but it is part of the process and a necessary one at that. And so even though I may not be doing a study, but learning from my co-residents on what they're particularly interested in learning, right at that time, to me, that would, especially when you figure something out that maybe hasn't really been explained in that manner or hasn't been talked about much at all, was really, really cool. Obviously, I would say to the younger people coming up, students and residents, is first know the textbook, know what's in the box, know what the standard of care is, then make that jump. And like Cal was saying, I just had some great mentors that I read McGlamory cover to cover when I was a student, and then what next? And I had mentors that kind of held my hand a little bit and guided me along that. I'll say now, currently, what makes it a bit difficult to do peer-reviewed publications for me is I'm employed by a small community-based hospital with no IRB. So it was just recently that I got a grant to go through a centralized IRB. So, and we have several studies that are waiting to be in print that have been accepted. But so for the last, 8-10 years, I haven't really been that active in research. I have a lot of unpublished manuscripts that, just because I didn't have an IRB, didn't have that opportunity, never really got published. But quite honestly, that really didn't bother me that much, because I was doing it for me and trying to figure out, because I would have a patient that, didn't do so well, and trying to figure out what went wrong. I thought I did a really good job, and, trying to learn from your own failures kind of thing. So, so that being said, being in a small non-teaching institution is not where I first learned all this stuff, but I'm glad I did. Also, kind of like what Cal said, a great year for fellowship, but doesn't want to do it again. And now that I'm back home working where I am, I don't want to work at a big system. I can walk in my CEO's door unannounced, and we can, talk about whatever decision's been made. And I might not get my way all the time, but at least I understand. So, and again, I digress, but that's it in a nutshell. I've never stopped reading. It's just haven't had the opportunity to publish, up until recently because of the IRB stuff.
We'll circle back around on the book, because I wanted to ask you more about that. That's a great story. Thank you. Cal, how about yourself? How'd you get so inquisitive and finding all these different research topics? And I realize some of it's your ankle, but the floor is yours.
Yeah, I think I was always perpetually curious. I mean, I always have been. And I mean, some of the scholarships I got early on, whether it was or awards, they were poetry. And I'm not ashamed to admit that now, but back in the day, I wouldn't have told anyone that I got awards or scholarships for poetry. Hopeless romantic. So I was into poetry. I liked writing poetry. And I kind of went into school thinking that maybe it's been done before. Everyone already has the answer. And I was sitting in a lecture, and it had nothing to do with podiatry. It was like a chemistry meeting that was going on at Barry University. And I was a freshman or a sophomore, and I don't remember even why I was there, but I happened to go. I was already on campus. I was always on campus studying, trying to save gas money because I couldn't afford to get back and forth. Because like we all do, we go through those struggles where we're broke. And I remember sitting around, and someone was giving a presentation. It was a student. And I remember looking around at the PhDs who were in the room, the professors, and I remember them taking down notes. And I was sitting there looking at this student who had done this research over 2 or 3 years, and I'm looking at these PhDs who are their teacher, and I'm watching them take down notes. And I was watching them raise their hand and start asking questions to the student, and they didn't know the answer, and the student did. And they were following up with, do you think this could this? And then they started collaborating amongst themselves. And that's when I kind of thought, I remember walking out of there like, this is some student who's here at the university just stirred the interest in minds of these PhD people who are here to teach them. Like this is, you can make a difference. Like maybe they don't know it all. Maybe there's still stuff out there. And you take my perpetual intellectual curiosity military family. You don't speak unless you're spoken to. You're seen, never heard. And so I again, before Steve Spinner, I was kind of petrified to even speak up. And so I almost segued from my love of poetry and writing for poetry, my curiosity, and the realization that you can. It hasn't all been done yet. And the people teaching us don't know everything either. And that kind of research kind of segued into maybe that was my way to have a voice. I could explore my own curiosity, and I could also have my voice heard without actually having to stand up. Because again, I was petrified to stand up and speak in front of anyone. So that's kind of where it segued into that. And then, kind of like what Pete was saying, just it's our curiosity. And then I wanted to know answers. So little stuff like, does fellowship make a difference financially? How's no one ever looked at that? There's a lot of things to control and a lot of things to look up in equations. And, do we burn out? The MDs and DOs had a ton of research on burnout. Do we burn out? No one's ever looked at it. Why not? Syndesmosis. Can you overcompress it? Does it affect the contact surface area? All these different things I did. I looked them up because I was curious, and I realized that no one had published it yet. And I figured, well, I can sit around and wait probably 2, 3, 4 years, because that's how long these things take. Or because I probably have more time than these people who are in practice and juggling families and doing all this stuff. Right now, as a student, is my time to just be a sponge. And I can attack these topics and really go after them because I've got the time. My time right now is to give 100% of my effort and my day to the profession and build this foundation. And so it just kind of, momentum, good or bad, it's a hard thing to stop. And so I started good momentum, and it kind of just carried itself from there.
Yeah. If you don't mind, Jeff, I thought of a good story that I can remember. I was a fourth year, and I got a question at an externship about wile osteotomies. And to that point, it wasn't really talked about, in our surgery class. And so I didn't know much about it. And we had to do a research project during our fourth year. And so I was like, perfect, don't know. I'd never seen this done. And the question was regarding complications with it. And nobody really said, there were different reports of saying this rate, but nobody really just compiled all of that, data and information. And so in the research project, we had to make a poster. It was a student poster presentation. And I was really proud of all this work, but it didn't make a good poster in hindsight because it was just data. It was based on no good case kind of thing. And I remember being so disappointed that we didn't win, but we might have even gotten last, my group that did this. And I remember talking to you and Dr. Steinberg that you were judging. You said, yeah, this is not a good poster necessarily, but you should publish this. And still I published that as a fourth year podiatry student. And I still have more citations from that paper than all the rest of them combined by far. And it was just because, like Cal was saying, that you start getting curious and you want to look up the answer yourself. And then you're kind of getting mixed signals. It just means that nobody's really compiled or really, hashed that stuff out. And so in some, there's opportunities like that as a student, because it's just a lot of reading. And you know what? I end up learning a lot more than what was published. And that's what I needed at the time. I didn't have access to patients to do, actual research, but I could publish off of other people's research, and it's kind of two birds, one stone. And that I, still get asked about that paper, and I can remember being a first year resident, and somebody came to talk to us to do a lab, and they referenced my paper, and one of the ortho residents said, "Hey, is that your dad that published that?" And no, that was me. And it was referenced on ortho bullets for the longest time too. So, like Cal's saying, you don't have to look very far to keep yourself busy and curious.
Absolutely. And I don't think sobering is the right word, but to allow yourself to think that perhaps you as a student or a resident could contribute to a body of knowledge to help the profession, that can help patients. It's hard to realize that initially, isn't it?
Yeah, I guess I didn't realize how naive I was, that I just, kind of thing. But but ultimately the goal wasn't ever to be published necessarily. The goal was really to win the poster presentation, but probably the bigger goal was never to get a question wrong about why osteotomies and their complications, and so so I guess it's kind of one of those things that when you're doing things for the right reasons, the good, byproducts or unintended successes often come from if you're doing things for the right reasons.
Well said. Well said. Cal, you want to add to that at all?
Pete's bringing up old memories of all the wild PIM questions when I was an extern. probably from your paper, Pete.
So let me go on to another topic that we've been texting back and forth, kind of getting ready for this podcast. And I noticed in both of your CVs that you both have patents. And I've always told students, I said, a lot of people are innovative, but not many people take that last leap and get a patent, because the hallmark of innovation is a patent. And as I commented this morning, between the three of us, we have 5 patents. There's been less than 12 million patents given out in this country. And all those 5 patents were within about 2 years of each other. So I'm super proud of you guys, first of all, for that. And I was wondering if each of you would take some time to talk about how that evolved, because it always evolved slowly for me. And I don't know how it evolved for you, but talk about your patent and the process of getting one. Cal, if you wouldn't mind starting.
Yeah, I think mine was, again, kind of like Pete, I was always reading the literature, always trying to learn, trying to be a sponge. And, I went to Westside, and Westside we did so many ankle fractures. And so you're doing so many of one thing, you start to question, why are we doing it this way? Is this the right way? Is there a better way to do it? I remember one week we had a dozen or whatever ankle fractures. It was a lot. And I saw discrepancies between the attendings. I saw some do manual reduction, some use a clamp, some put it 1 centimeter up, some go 2 centimeters, some kind of just didn't even reduce it at all. Some just did. It was so much variability. I just thought, this is nuts. Like, how are all these people doing the same thing differently? Like, there's got to be an optimal way to do this. So I started looking at the research, and you can go down a rabbit hole pretty quick with ankle and syndesmosis if you want to. And I found one of the classic articles about how you can't overcompress the syndesmosis. Well, that led me to say, okay, well, why in this study did they find that? That's what I always tell the residents or fellows or friends or anyone I talk to is you really have to read the literature critically and look at the methodology, because that a lot of times determines why they got the result they got. And so I saw some things that I think they did the best they could, 50, 60 years ago, but I chose to do things differently and use weight-bearing CT and do some things. And so then that kind of figuring out with CT that you could overcompress, and that was the first article that came out, that you could overcompress the syndesmosis, and some have come out since then. That kind of led me to syndesmosis and now reduction and optimal fixation. And that kind of led me towards my patent. And then having when you had your patent at the time that you ended up successfully selling, which was really cool to see. And you had departed Barry at the time. And we thought maybe gone off into the sunset.
Can't get rid of you that easy, Cal.
No, I reached out to you. I remember reaching out to you. I was in the garage at Westside, and I picked up the phone. I called you. I said, I don't know what I'm doing. Is this even worth even trying to do? Et cetera, et cetera. And seeing you and having you as an example, right? You to kind of guide me, even though to you, it might not have seemed like a lot, maybe 2 or 3 conversations, a couple emails, but that was enough to kind of give me enough confidence to go down the route of doing my own research and what's the provisional versus non-provisional and going through that process and, ultimately getting the patent. So, and I tell everybody, if you have an idea, make sure you protect it. I've had ideas taken. I've had ideas gone successfully through. A lot of my successes in life are balanced with equivalent failures too. So I've learned a lot of tough lessons that I try and steer people away. But I would say having you as an example and someone who I saw successfully take from start to finish, without seeing you and having someone personally that I knew that did, I probably would never have gone down that road. Because you say patent to anyone, no matter what they're in, and they just say, "Oh my gosh, that's a long process. It's expensive. You have to go commercialize." It's very discouraging. And so seeing that you had success with it kind of pushed me down that hill to start, at least. I don't know what pizza is. I don't know if pizza is similar to that.
Well, I appreciate it. I didn't realize I had that influence, but I appreciate it. Pete?
Yeah, so I think it kind of piggybacks off of what we're saying about the research of being curious. And when you realize in surgery, hey, I think there could be an easier way to do something, or a safer way, or just a more efficient one, or a more financially viable way, because cost of implants and instruments is not very cheap. But so how my bone grafting projects came about is I was using a harvester that's pretty popular today. And I was, in the proximal tibia, elderly lady with big hindfoot fusion, kind of thing. And I needed a lot of graft. And when that lady came in, because that harvester was so aggressive, she ended up getting a stress fracture of her plateau. And I felt terrible because I felt like I had harmed somebody, even though you're told by the reps somewhere, oh no, you can't hurt. Yeah, it's fine, whatever. And I can remember losing sleep over that. And that, like there's got to be, a more efficient way than just using curettes. And then you got all this soggy bone that's not very, doesn't have very good handling characteristics. But something in the middle that is safe, but also is not super expensive, but also could improve the handling characteristics. So, I started looking in the spine literature because they're the gold standard for bone graft, and they're far above us, at least advancement wise. And then I started thinking, well, there's got to be something else on the horizon. And so I got on LinkedIn. This is like the only productive thing that I've ever had happen on LinkedIn. I reached out to a startup, a neurosurgery startup, and I said, hey, you guys are doing some bone grafting stuff. I think there are some, modifications, additions, but based on the concept of some of your existing products, I think this could be used for foot and ankle. And we're the only two specialties doing a lot of fusions, right? And so the CEO at the time, one of the co-founders, got back in touch with me, and it took off, and was great because I was had him initially as a mentor, but he'd already been through the process, and so I didn't have to necessarily invest my own money in it, so I could do it kind of in combination with, and so that led to two different types of harvesters. One intermediary when you're doing nails, because all that cancellous bone typically goes on the floor, or if you're somebody who does it by the book and lets down the tourniquet, you got so much blood mixed in with it, and so once it's all collected, there's a device, sort of like a French press, that will basically separate the liquid from the solid graft. And what is probably one of the best characteristics of it, whether you're using it for the IM technique or if you're going from proximal or distal tibia or the calcaneus, is that bone is already morselized, and so the handling characteristics are extremely improved. It almost handles like DPM now, but it's autograft. And that's a billable procedure. And the device costs about $550, list. So it's very inexpensive, and it's really not that, wild and crazy, didn't have to have a team of engineers figure it out or something like that. But, it's really starting to kind of come out and hit the market. That company's trying to get into the foot and ankle space. So hopefully, that'll be advertised to us soon. But I've used it successfully over 150 times without a complication, and it really doesn't add much time, if at all, to the case. And now I can harvest, especially for IM nails, while the scrub is swapping out the reamers. I'm collecting graft, and it's just this back and forth kind of thing. And so it's like one thing leads to the next, that leads to the next, leads to the next. And the last comment I'll say about the handling characteristics is, I love 3D printing. I think that might be kind of more my niche in things, at least currently. But no matter what company you use, they all have this porous structure that it's hard to get autographed into. If you're just curating it out or using something existing on the market. And so, you can't do both, the kind of thing. Now you have to add a bunch of biologics, which can be very expensive. And these are already very complex cases with very expensive implants, and risks are very, very high. This is something you're throwing the kitchen sink at, right? And so having those handling characteristics using the bone press, now I can pack all that autograft in and then supplement with any biologics I want to. Technically you could take the liquid portion of the graft and spin it down in a centrifuge. We haven't done that yet, but that would be the obvious next step, because there's useful cells in there. But anyway, that's it in a nutshell. And I will say, one skill that I learned in that whole process, as well as some other kind of innovative processes of product development stuff, is how to sketch. I think I've taken every YouTube video lesson on how to sketch, because when you're trying to explain something to a patent attorney, they're billable hours. And if you can show them a decent picture that looks better than what a second grader would do, it will save you a lot of time. And it's also a better conversation to have with the engineers, because, they're also, very visual and mechanical naturally. So trying to describe what's in your head is not always the easiest thing. And so it's funny, the skills that you start to kind of learn, trying to get to the ultimate goal. Like we said, it's not easy, and it can be very frustrating and time consuming, but man, it's enjoyable. And especially when you finally see it come to fruition, it's like, all right, that was time well spent. But then very quickly you're like, okay, what next? What's my next creative project?
Mm-hmm. Yep. It's like you get one mountain and you need a bigger one.
Yep.
Couple things about that. I've noticed when I've been doing patents and working with engineers that I would bring them into the clinic and I'd have them see patients with me. And because engineering is very black and white, so they will design whatever you want them to design. They'll use SolidWorks and all these other, engineering software programs. And then when they don't work, the engineers used to turn to me and I'd say, we need to tweak this. We need to do this. We need to do that. And they'd say, but Jeff, we made it to spec. So you're absolutely right. If we can give them a vision of what to do, it makes a big difference.
Yeah.
Very good. Couple thoughts I have, because this is, we could probably sit here and talk for 2 hours, right? So I was thinking maybe I'd ask you a couple more questions, and then I'd be interested down the road, not too far from now, of getting together and doing this again, and maybe bringing in another one of my friends that has some patents and talk specifically about the patent process. Because I get asked about it all the time. And I don't know if I'm ever really providing much help, but I try to help mentor people. And I think that might be a really neat discussion that the three of us could have going forward too.
Well, it would definitely be something I would listen to if I'm not talking, because I know I still have a whole lot more to learn about it, kind of thing. It's just not our specialty, right? Kind of thing.
So let me ask you each a couple questions. What's the most interesting case you've ever done, Cal? I mean, you've been doing a lot of revisions and things, and maybe it's hard to differentiate them, but what's the coolest case you've ever done?
It changes month to month. I can't give you one. I just can't. Revision work. That's what I love about revision work, is it's always, there are great surgeons out there and things go south. And it's not because they didn't do anything wrong, but they might have missed a thing or two, or some non-compliance, or there's something that maybe they weren't exposed to in training that you have been. And so for me, the revision work I love, and I can think of a couple that I love off the top of my head, but even like today I did, the last case I did was a complete show part dislocation, dorsal dislocation, fracture of the cuboid calcaneus, naviculus completely sublux, Charcot, uncontrolled diabetes, happened 4 days ago. show part dislocations almost never happen. Like that's super rare. The subtalar goes first or the midfoot. It's always the midfoot. So the show part, that was getting that reduced and having to do a mini incision and get a cop from the hip in there and get the spring ligament and everything that was interposed out of the way. That was cool. I mean, I love revision work. That's not revision. That's just trauma staging, to put an X-fix on, stabilize everything, come back to fight another day. But like, that's a cool case. I mean, how many of us do that in our career? I probably might see one more of those in my career. Maybe not.
You had to go back all of like 6 hours.
yeah. So that was and that's a really cool case. And then, some of these cases where I had a great case where a lady was locked in varus. She had a subtalar fusion, locked in varus. We all hear that adage, you shall not varus, right? And, sure enough, her whole medial column was up. Her transverse tarsal was locked, going in there, getting that hardware out, sliding everything over, releasing the tarsal tunnel, bringing everything back down. I can't tell you one case because every revision case, I sit back sometimes at the end of the month and go through these cases. I'm like, man, this was the coolest thing I've ever seen. And then I'll go to the next month. 2 months ago before that, I'm like, I don't know, this is really cool too. This makes for I've got a great revision PowerPoint of probably about 40 or 50 cases now where I want to sit down and go through each revision case and what my rationale was and why I did it and why it worked. And I've had some that you have to go back and you revise your own case. So you take on a revision and they're a 4 or 5 time loser and you lose 2 the first time around. So it's not always a home run the first swing. But I think, that's when it gets into the whole patient experience. I'm sure we'll talk about that. The whole thing is putting the patients first and the patient experience and everything else. And people know when you care. I think as doctors, we think that sometimes they're a number, or you look on the schedule, you've got 30 patients, 40 patients, or you've got to operate in the morning, you've got to go here, and you've got someone who's calling you, and you've got something else to do in the afternoon, and family obligations, and people get sick, and you have deaths unexpectedly, and things happen. But when you go in there and you walk into a room and the person knows that you actually care about them, there's a natural intuition. It doesn't matter what education level you have. There's a natural intuition everyone has where when they know you actually care about them and you make that connection, they're going to stick with you. Doesn't matter if you swing and you take a miss and you lose. They trust you. They're going to stand right by you and you'll get through it together. And that's the most rewarding part of what we do, I think, is that we get to see a tangible benefit. People come in, I am hurt, and we get them back on their feet. Whereas one of my friends is, oncology, and that's a area where most of the time they lose. And so for us, I think that's one of the reasons of the hundreds why I love our profession is people they come in with wives, husbands, girlfriends, boyfriends, kids, moms, dads. They've been affected for a really long time. They've been with this. Some of these patients have had 5-6 revisions over the past 4 years. They're desperate. And when you help those people, even if you can only get them 60% pain relief, you have changed their life forever because they're finally walking again without a scooter and all that. I mean, it's just, I can't imagine doing anything else with my life. I really can't.
That is very inspiring and great story. And it's more of a philosophy than a case, right? And
right.
That's really cool. Peter, how about you? What have been some satisfying aspects of your practice, specific case you want?
To piggyback off Gal said, revision, post-traumatic, kind of unique stuff, Charcot stuff, particularly anything involving the talus. I'm very, very interested in those cases. Stick with me. But in particular, the first 2 cases, going back and forth on which one I would pick, but the first would be my first 3D printed total talus, which is 6.5 years ago or so. Up to that point, it hadn't been published on. I'd only heard that Salem Perec had done some, and reached out to him, and he was the only one, and I didn't know him at the time, but how gracious he was with me. I knew I could figure it out. It's just not doing something, and there's no book to. I definitely probably took a few years off my life on the month leading up to that case, and not sleeping much, but how satisfying it was, and again that just opened up a door and really kind of changed my practice. And I was already doing a lot of revision and post-traumatic deformity kind of stuff. But probably my favorite one, and Cal also said this, I'll probably never see this again, was a middle-aged lady that had a Liz Frank fracture with a nutcracker cuboid fracture. And she comes in, bad midfoot arthritis. Most of her pain is in the CC. Well, I should say the CC, but the CC and the cuboid fourth, fifth met. And there's not much you can do there. I can take care of, the central and medial columns. That's no problem. So I guess timing's everything. That's when I was really starting to get into 3D printing. And so said, we can probably shorten her medial and central column with the fusion. That's going to give us a little bit more space. If we can get that whole cuboid out, and based on our CT and our MRI, the cartilage on the calcaneus and the metatarsals looked pretty good. So the cuboid had already collapsed, and that's what was avascular. And so popping that out and replacing a cuboid, I'll probably never get to do that again. Hopefully it'll be in the literature. It's been accepted for publication now for like forever. But yeah, that and again, like Cal said, this lady had been told nothing you can do for that. You can take care of the part that doesn't hurt, but and just the willingness to try, but staying in your lane too. Of that was a very complicated case, and fortunately went really, really well. But yeah, that takes the cake, because I won't ever see it again. I'd be surprised if I do.
That's a cool case, man. That's a really cool case.
That is, if we can agree that we'll do another session down the road, that'd be great. We can put some of these other topics I have on the back burner right now. What would each of you say to a prospective student who's contemplating a career in podiatric medicine? Cal.
I was hoping you would say Pete go first.
Or Pete, you can go first.
I would say, I should preface this by, I was one of the, I think, few people that sort of knew what I wanted to do from an early age. I remember writing a paper in sixth grade about what do you want to be when you grow up, and it was a surgeon. Don't ask me why, because there's nobody medical in my family, but it was just, I kind of saw them as, a modern Renaissance man, the guy that can fix things with his hands, but in the body, growing up on farms and working on farms and turning wrenches. I guess that was just the next step. And so what I would say, from my experience is don't forget what it felt like to be a child and a kid that can dream, and don't ever be afraid to take a big swing, because you won't regret it even if you miss. And ultimately it will open up other paths and other opportunities. It's the old adage. It's the not trying that people end up regretting, when they get older in their years, so I would say, obviously from my experience, it can be a very, very rewarding profession, and you can make it what you want. That's the one great thing about podiatry is, if tomorrow I say, you know what, I'm going to go be clinical, there's nothing wrong with that, and I can do it, and it's seamless. If I say, you know what, I don't want to ever do ankle replacements anymore, or I don't want to ever do hammer toes anymore, you don't have to. And that was probably one of the best pieces of advice that I got from an orthopedic surgeon who was a mentor that I rotated with in undergrad. Was, he said, pick a surgical specialty that you have a lot to pick from, because you do anything 1,000 times, it can get mundane. And it's just a little bit, there's never going to be one of us that's, doing, 500 total ankles in a year. Like there are guys doing that many knees. And that's a good thing. But that also means we need to collaborate more and work together. But so I guess that's my 2 cents.
Fantastic. Cal, you're on.
Yeah. So Pete he jogged my memory just now. He was talking about one of his orthopedic mentors, and I guess what I would say to someone who was thinking about podiatry is I remember a conversation Greg Burlett and I had when we talked about, what do you want to be? How are you going to be that? And why do you want to be? Why? Like, well, at the end of the day, what's your why? And so I'd ask a student, podiatry, what do you want to be? I want to be a surgeon. Okay. So you're thinking about foot and ankle surgery. How do you want to go about doing that? Do you want to do fellowship, non-fellowship? Where do you see yourself? It kind of goes along the lines of Simon Sinek. I don't know if you've ever seen Simon Sinek stuff. But for me, when I decided podiatry, I said, I want to be a podiatric surgeon, foot and ankle surgeon, whatever you want to refer to it as. Okay, well, how are you going to do that? Well, I want to go to a good school. I need to surround myself with people who are willing to invest in me and help take me to that point. I want to be really active in research. So there's not a lot of foot and ankle research. I want to be really active in research. I want to lead by example. I want to stay, come earlier and leave later. I want to have a really good work ethic. I want to help people around me. And then, kind of at the end of the day, why, and the why was important, especially when things go south in your personal life and your career might be all you have. And that did happen to me at one point. Why am I doing what I'm doing? Because I'm making a huge impact on people's lives, and you can see it. It's not about reviews; it's about the cards and the gifts. And I tell patients I like carrot cake, right? And so I get carrot cakes every month from different post-op patients, and I'm doing it because I'm making a tangible difference in people's lives. And even though I might see thousands of patients a year, they're going to remember that difference I made forever. And so that's someone's life that I'm going to be able to have helped and made better than had I not been there. And then two, on the flip side, outside of the patient aspect, I loved research. I love writing. And as I started to develop a voice, people kept saying, well, you can't do it all. So you got to pick. Do you want to do consulting? Do you want to do research? Do you want to teach? Do you want to just be in private practice, make a lot of money? You can't do it all. And I said, I don't know. I think you can be in private practice or a hospital. You can do research. You can innovate. You can teach. I think you can do it all. So going out there and doing it all, quote unquote, like Pete. I mean, Pete, I've been following you. Everything you're doing is incredible. I'm sold on your bone graft harvester from earlier. That was get it in my hands and I'll use it. Being like Pete is, being an example to the future generations and showing them, listen, you can do it. Just because no one else did, there are guys out there that are doing it. You can do what they're doing and go even further and take it to the next level. And so it's improving patient care and driving the profession forward at the same time. What's a better why than that? And when things got tough for me, those two things, this profession has been everything to me, and I don't know what I would do without it.
Oh, well said. Well said to both of you. So we're running short on time. I want to put out an open invitation for both of you to come to Arizona and give some talks with my classes. And don't come in the middle of summer, though. Wait a couple months. It cools off a little bit. But again, thank you for your time, your expertise. You're young in the field still, and you're so accomplished. I'm so proud of both of you. So great work.
Good. I will.
Thank you. And I think Cal would agree that you have been a great mentor to so many, and to inspiration, and a guy that has done it all, and pivoted in your career, and always been useful and given back. And so I don't think, speaking for Cal, we couldn't be more grateful for you. And so opportunities like this, I can't say no to you, put it that way.
All right. Well, thanks, guys. I really appreciate it. So we'll come to a close. Again, I thank you for your time, and to our listeners, we always appreciate you tuning into the Dean's Chat. We'll continue to bring leaders in the profession to this podcast. We're definitely going to get Pete and Cal back for another episode down the road. And if you're watching on YouTube, be a subscriber. If you're listening to podcasts on Spotify or Apple Podcasts, please give us a 5-star rating. And until next time, cheers.